So we're going to spend the next few minutes talking about diseases of the pancreas and gallbladder. As usual, we are going to start with some cases. So a 28-year-old female patient presents to the emergency department with a 2-day history of right upper quadrant pain and vomiting. On examination, she's afebrile, has guarding and rebound tenderness in the right upper quadrant associated with a positive Murphy's sign. So just pause the video, think about what this could be, and think your way through the pathophysiology of the condition, its clinical presentation, epidemiology, and complications. Yeah, so this is cholelithiasis and possible cholecystitis. This is a condition in which there are calculi within the gallbladder, usually cholesterol stones, and these can occur because of bile stasis or infection, increased cholesterol concentration in the bile, and are associated with certain risk factors such as female sex, obesity, pregnancy, certain drugs, and there is a hereditary component as well. Bear in mind, there can be other stones such as calcium, bilirubin, or pigment stones. Many patients are asymptomatic. The ones with cholelithiasis often develop right upper quadrant pain, may be associated with fatty meals, or patients may present with complications of cholecystitis, cholangitis, or pancreatitis. The initial investigation for this is the ultrasound, which can detect the stones and features of cholecystitis, which would be cholelithiasis plus an ultrasonographic Murphy's sign, thickened gallbladder wall, or pericholecystic fluid. CT scans are often not necessary but may be used to rule out other differentials or identify some complications. And ERCP is used in specific situations such as cholangitis or choledocholithiasis. So let's think a little bit about choledocholithiasis. These are gallstones in the common bile duct which are causing obstruction to bile flow. And patients often have obstructive jaundice due to impaction of the stone in the ampulla vata. Courvoisier's law states that in the presence of a palpable gallbladder, obstructive jaundice is unlikely to be due to gallstone. So when you have a patient with obstructive jaundice, if you can palpate the gallbladder, it's unlikely to be due to gallstones. Ascending cholangitis is an infection of an obstructed biliary system, and the triad of clinical features includes fever, jaundice, and right upper quadrant pain. These patients may develop sepsis, hepatic or renal failure, and hepatic abscesses. So this is a real surgical emergency. Have a look at these two pictures and tell me if you can think about what specific gallbladder related conditions are being represented here. You may pause the video and have a proper look. Okay, well, on the left we saw acalculous cholecystitis, which is infection of the gallbladder without stones, and this may be seen in patients with sepsis, diabetes, and pregnancy, as well as some other conditions. These patients may go on to develop emphysematous cholecystitis or gangrenous cholecystitis or extrabiliary abscesses. Emphysematous cholecystitis occurs in patients with impaired vascular supply, often in the presence of gallstones, and in patients who may be immunocompromised, such as diabetics or older patients. It's really the presence of gas-forming organisms within the infected gallbladder. These patients are quite unwell. They need full workup, including imaging, such as a CT scan or ultrasound, and treatment requires prompt resuscitation, antibiotic therapy, and they may develop quite serious complications including septic shock and death. Okay, so case 2 is a 54-year-old female, severe abdominal pain and vomiting, marked epigastric tenderness with guarding and rebound. Serum amylase is 432 international units per liter, and the serum lipase is 628 international units per liter. So this, of course, is acute pancreatitis. The two common causative factors are alcohol and gallstones, and you can see there are different gender predilections. What really happens is that with obstruction to outflow or damage to the gland, then you have premature activation of enzymes, exocrine cell injury, and autodigestion of the pancreas. You would know the clinical features of acute pancreatitis. You can assess the severity by looking for evidence of organ failure, the presence of complications, and or the use of scoring systems. These patients need proper resuscitation and investigation. CT and ultrasound may be helpful mostly in identifying complications or looking for other causes of abdominal pain. Treatment is mostly supportive and resuscitative. Sometimes prophylactic antibiotics are given. Complications include sepsis, shock, multi-organ failure, including ARDS, and the development of pseudocysts, abscesses, or necrosis. So let's have a look at some pancreatic scoring systems. The first is the Ransom criteria, which is never completely useful in the emergency department because it does include parameters that we only look at 48 hours after admission. The BISAP criteria are much more suited to the emergency department, and this is the BISAP score. This is one that you need to know, so you may want to pause the video and have a proper look. What are the complications of pancreatitis? Again, you might want to pause the video and think about these complications. So we're going to talk about pseudocysts. They tend to be caused by extravasation of enzymatic fluid, often seen in alcoholic pancreatitis. These patients are diagnosed because they have a persistent elevation of the amylase and lipase or persistent abnormalities of their liver functions, and then the diagnosis can be confirmed on CT abdomen. Treatment is supportive and conservative, although field conservative management may require endoscopy or surgery. Abscesses, on the other hand, form 4 weeks after initial illness in about 3% of patients. Pancreatic necrosis leads to a collection of dead tissue and fluid, which can then become secondarily infected. Patients with persistent symptoms following severe pancreatitis may be developing a pancreatic abscess, but bear in mind that 50% of patients may be asymptomatic. A persistence of an elevated white cell count, abnormal LFTs, or elevated amylase and lipase may clue you in to the diagnosis, but these tests are non-specific and not sensitive. Once we consider the diagnosis, a CT abdomen is the imaging of choice. And again, treatment is supportive, but the abscess may require drainage, either surgically or via endoscopy. We're going to look at a chronic alcoholic with chronic epigastric pain radiating to the back, weight loss, and abnormalities in his stool. This is chronic pancreatitis, usually caused by current episodes of acute pancreatitis, and it could be either gallstone or alcohol related, but seen in males more than females. Patients present with chronic or recurrent pain, malabsorption, and the diagnosis is made via blood investigations and imaging. Patients develop malabsorption. They may develop diabetes mellitus due to destruction of the islets of Langerhans, and it's associated with an increased risk of pancreatic carcinoma. Pancreatic carcinoma is seen in patients who have increased alcohol intake or smoking, can be a complication of recurrent or chronic pancreatitis, and does have some hereditary component. Clinical features tend to be non-specific, and the diagnosis can be hard to make. Although obstructive jaundice is one of the features, it tends to be a late feature and only really associated with carcinoma of the head of the pancreas. Blood investigations are non-specific but may help with staging. However, mostly other imaging is needed, such as CT, transcutaneous ultrasonography, MR scanning, or ERCP. It has a high mortality, and spread is initially direct to other organs or intra-abdominal. So that was a very quick tour of diseases of the pancreas and gallbladder which you need to know for your exam. I would suggest that you use this lecture as a springboard to study these conditions in more detail. Thank you.